you see here, the cusps are fused. And then if you look here, this is a bicuspid valve. And the bicuspid valve, the two cusps right here are fused. So there's a slit right here, like a crescent shape that is there. And then this is extremely rare. And this is where you just have no cusp at all, unicuspid valve. So this is how it looks in real life. So this bottom image right here on the right is actually the calcified aortic valve. This right here, you can see the slit. This is a bicuspid valve. This is a healthy valve. This is what every one of us's valve is supposed to look like and function normally. And this right here, you can see the fusion of the commissures. This is a rheumatic valve. So this is the pathology of aortic valve. The problem with that is patients end up developing lots of symptoms, the majority of which is shortness of breath and fatigue. The thing that happens though, when we see these patients in clinic, they always attribute these symptoms to growing old. When you have an 80-year-old in clinic, he says, I'm old, I'm supposed to be out of breath and tired. When in reality, that's not the case. It usually is manifested from the valve. It's a progressive disease. So what does that mean? It means if you develop the disease, if you develop the pathology, it will continue to progress. It will continue to get narrower and narrower. And so the best way to think about this is if you have a garden hose and you put your finger on the garden hose, the area starts getting smaller. So the amount of water or blood in the case of the valve has to pass through that small tiny orifice, and so that ends up going faster. So if you put your finger on the hose, the velocity of the water coming out of the hose will become faster, and in that case that leads to increased velocity. So we use the same idea to diagnose aortic stenosis, and the way that works is using echo. So if we put an echo probe on the chest and we send ultrasound waves towards the heart, the ultrasound waves will bounce back off the red blood cells, and then the machine will do some calculation and determine how fast the ultrasound wave went, and how it reflected back, and then calculate the velocity. And that's how we classify the severity of the valves, whether it's mild, moderate, or severe. Severe being with an area of greater than 4, a mean gradient greater than 40, and then it uses calculation to calculate the area, which is less than 1. The problem with aortic stenosis is once someone develops symptoms, and you can see it right here, their trajectory to die is very steep. So once you're symptomatic, you will pretty much crash and burn. And so people mostly will die within 2 years, and the majority within 5 years. And it's not a very subtle death. It's not a walk in the park kind of thing. You will develop angina, you will develop syncope, you will continue to come to the hospital constantly for diuretics because you're now having heart failure. And so this is, it's a deadly disease. Once you develop it, it will progress to the point that it will kill you unless you fix it. So the idea of fixing someone with a transcatheter approach, it was thought about in the 1980s and 90s, but it never came to fruition until 2002. So back in the day, if this is the progression of valves, the first 3 valves are surgical, but then in 2002 is when the first aortic valve was developed, a transcatheter approach. But if you could see that even though the first TAVR was done in 2002, it really did not kick off till 2011. That's when they started doing the partner trials to determine if it's safe or not. So like I said, the first one was done in 2002, and it was done on a 57-year-old man. So if you have someone who's 57 years old, and there's a difference in culture between America and the Middle East, but in the Middle East, pretty much people would just not do anything for this person because one, lack of expertise and lack of equipment. But here, 57 years old, for us in the United States, we're going to do everything we can to save this patient. In our book, 57, 60 is extremely young. Our average age in structural field is about 85 to 90. That's the average age that we deal with. So when you see a 57, you're going to do everything you possibly can. So they offered this guy a TAVR procedure. It was the first one ever done. He eventually did die. But again, remember, this is the first procedure to ever be done, and this is how it was done. This is Dr. Alan Carabare, who passed away not too long ago, but he was the first one to do it. So what is the valve? So the valve, the aortic valve is made out of the pericardium of the cow. So they take every day a mass shipment of pericardium of the cows gets shipped to 3 factories for Edwards and other factories for the other valves. They get shipped there and they process the pericardium. And then once they process the pericardium, they cut cusps out of it, and then they manually hand suture every cusp to the valve. And so once they do that, this is how it's done. And so an assembly line pretty much. So the valve starts on the top right here. They do some work. They pass it on to the next person, to the next person, to the next person. And by the time it gets to the last person, the valve is complete. And so let's say someone in Jordan gets a TAVR valve. The person in Jordan can know exactly who sutured his valve, even though they're in completely different parts of the world, because they keep an accurate database of who sutured what valve and which patient got that valve. So that's one thing. So then the other question becomes, how do you get that valve in the body? So I have actually a real valve right here. Let me get it. So this is an actual real valve. And if you can see, this valve is not going to fit through an artery, right? This is how the valve gets sutured. This is how it looks from the inside. And this is how it gets shipped to the hospital. But how are you going to put this valve through an artery? You can't. It's too big. The artery is not this big. Even if you go through the biggest artery, you can't. So what you do is you put this valve into the white device right here. It's called a crimper, and this valve will crimp this. The device will crimp the valve. It will squish it on top of a balloon on a delivery system, as you see right here. And then what that does is it makes the valve smaller, and you're able to get through the artery, travel to the heart, position the valve, and then use a balloon to inflate the valve back in position. And that's how the concept of TAVR works, or that's how actually the concept of most of the structural procedures work. And you will see this as we move along. So this is an animated example. You go through a tiny hole in the leg, you travel all the way to the heart, and then what you do now, because remember, we said that the pressure in the heart is very high, and the pressure across the aortic valve is very high, that in order for you to drop the pressure, what you do, you have to stop the heart. So how could you stop the heart without doing open heart surgery? And that's the thing about structural cardiology that you will learn as we go along. Structural cardiologists have to think outside the box. This is how we are developing technology. We're constantly evolving. There's new innovation because we have a problem. We have to figure out solutions, and we can't use the typical solutions in the box that we've always used. So we always think outside the box. So we found out that if you speed the heart very fast, if you pace the heart at 200 beats per minute, you stop the heart without stopping the heart. So what you do is what you do is you turn on a pacemaker. So this wire right here, this is a pacemaker that's coming in, and we put it in the RV, and then we turn on that pacemaker to 200 beats per minute. And what happens, the heart's doing this, and then it starts doing this. When it does this, the pressure of in severe AS, it's going to be 170, 180, will drop to 40. And the reason you need the pressure to drop is because when you inflate a balloon and you have pressure of 170 hitting the balloon and the valve, what's going to happen? It's going to shoot out of the aortic valve, and it's going to go down into the aorta, and it's fatal. Patients will die. And so you can't, for the untrained eye, you probably can't see it, but this is how we look at it, gray and white. And then right here is the heart. And right now, the heart is quivering. You can't really see it, but if you look at this border, the heart is actually quivering. So the pressure dropped. And then we take that 20 seconds. So we have 20 seconds to position the valve, to drop the pressure, to inflate the balloon, deploy the valve, deflate the balloon, then stop the pacemaker. So, it's a very quick procedure that's very meticulous. And then on the next shot, this is how the valve looks. So this valve is now working normal, and the coronaries, as you can see on the top, they're not obstructed. And this is something else you have to look for because that can be fatal as well. So this is what it takes. It takes a team, it takes a lot of equipment to make this happen. But now, one day, someone did a CT scan. This is one of my patients. And then on that CT scan, you have this big chunk of calcium right here. So this is the valve right here. Could you guys see my mouse, by the way?
Yes.
All
Yes.
right.
Yes, we can
So
talk
this
to it.
is the valve right here where my mouse is. But if you look underneath the valve, there's calcium. And what happens if I were to bring the same valve that you just saw, which is a balloon expandable valve, and I deploy it here, this chunk of calcium is going to go somewhere. And it could rupture the aorta, it could kill the patient, it could cause significant paravalvular leak. So now we have a problem. We have to fix that problem. And the way to fix this problem, the idea of not using a balloon expandable valve, using what's called a self-expandable valve, something where you unsheath it. So if you pull something back, it starts opening. So that's what we did in this case. This was 2 weeks ago. So, but what you have to do, you have to inflate it with a balloon, but we inflate it with a small balloon. So rather than inflate a 1-to-1, we would use a smaller balloon to open it just to be able to get the valve in. So that's what we did. So this is from 2 weeks ago. You see this dark right here? This darkness is the calcium. And you saw how it behaved. So that we inflated a smaller balloon. So this is not a full-size balloon. And we just opened a pathway. Once we did that, we took this valve. So this is called an evolute valve. It's a self-expanding valve. And the way this valve works is you unsheath it. You have to be very delicate to do this, by the way, because you don't want this valve also to go somewhere else. And then the way this works is you start unsheathing this valve until it's fully deployed. And there you go. Now you were able to do a valve, you solved the problem, and the patient's doing well. And this is a big valve. So if you look right here, I have a real valve for it. It is a big valve. So you have to be also cognizant. It's a very meticulous procedure. So we need CT scans to be able to determine all this. Every single one of us here has a different sized valve. So we have to know what size valve to use. We have to see if there is calcium, just like you saw in the second case. And we have to also make sure we won't block the coronary arteries that are coming off from the aortic valve. So how do we get the valve to the body, into the body? So there's different approaches. There's the one that you go from the leg, so from the femoral artery, and that's the majority of the cases. And if you have a problem in the femoral artery, other options are you go down the carotid. So you open the surgeon that's with you, he opens the neck right here, and then you puncture the carotid and travel down the carotid artery to deliver the valve. And then on the way out, you guys close it. One other option that that it depends on your hospital that I was trained in is called the transcatheter. This is a little interesting, and the way we deliver the valve here, if you have a problem in the femoral, you go into the femoral vein, you travel up into the IVC, you puncture the IVC, you puncture the aorta, and then you send the wire all the way up to the top, as you see here. Then you put in your equipment, you go to the valve, you deliver the valve, and then on the way out, you put a plug. And that's called a transcaval approach. And again, there was a problem that had risen, and people had to come up with a solution for this. And this is thinking way outside the box. And then a lot of people will say, well, if there's a hole in the aorta, why doesn't the patient die? And the reason that is the pressure in the aorta is much higher than the pressure in the vein. So when the pressure in the aorta is high, it will push the blood out. But because the peritoneal pressure is also higher than the vein, the space right here, that will push the blood into the vein. So in other words, the blood will go out into the peritoneal space, back into the vein until it heals and closes up. And this is what structural cardiologists do. They think outside the box, and this is us delivering our sheath from the vein into the aorta to go deliver our valve. And So this was actually first done in 2013 in Henry Ford. And these Dr. Adam Greenbaum, Dr. O'Neill, William O'Neill, they are pioneers in structural cardiology. I had the great privilege. I was very lucky to actually be trained by Dr. William O'Neill. This is me and him. I was very nervous here as he's looking at me, but so he's one of the pioneers of TAVR and transcaval access. Luckily, this came out last week for TAVRs. Our hospital now is ranked one of the best in the nation, the top hospital in the nation for TAVRs. So moving on. So we talked about if the valve is narrowed. So let's say, does anyone know what this is right here, where my mouse is? So this is called a heartmate. So what's a heartmate? So a heartmate is a pump. So the surgeon comes in, he cuts the apex of the heart out, he connects a pump inside, so the blood is taken from the LV into the pump, and then there's a tube that goes into the aorta and it shoots it into the aorta. And this is done in people with end-stage heart failure. So I know, in Jordan we don't have this, but this is what this is. This is called a heartmate. So there are people in the world that are walking around with pumps that are connected to their heart, and then a tube that just shoots the blood back into the aorta. And they have a battery. They have a couple batteries, because if the battery dies, that will be bad. The pump will stop, people will die. So this is an example of a patient who's had open heart surgery, and they did a pump. He's end stage. So this patient, there's nothing to be done for. And then these people, their aortic valve does not function well anymore because the blood's not going through the valve. It's going into the pump. So we had a 79-year-old. He had a heartmate placed a couple years ago. And the problem is the patient still has shortness of breath and he's orthopneic. Okay. So we did an echo. So even though this is not very clear, this is the aortic valve right here. And this color, this orange color, is bad. So this is not supposed to be there. This color means the blood is going into the pump, out into the aorta, and then back down into the aorta, across the valve into the pump. So it's a cycle. It's a vicious cycle right now. It's a circuit that you have to break by closing this valve. But how could you close a valve in someone who's already had open heart surgery and major surgery? If you do surgery, the risk of death, according to the calculator that we use, is 26%. So if I were to, if I convinced a surgeon, which I wouldn't, to do surgery on this patient, there is a 56 morbidity mortality percentage for this patient. So you're not doing the patient good. Remember, we do no harm, right? So the way we have a problem now. How do we fix it? So we do the same exact concept. We take a valve, but what's different between aortic regurgitation and aortic stenosis? We said in aortic stenosis, the valve narrows because of calcification. And so we use the calcium to anchor our valve. It's like glue, because the valve, why doesn't the valve move in aortic stenosis? Because when we do a TAVR valve, we use the calcium to anchor our valve. In aortic regurgitation, there is no calcium. Calcium is zero. So how are you going to put a valve and not have the valve move? And so we had to create, or they had to create, these little hooks. You see 3 of them that will anchor on the cusp. And then once they put them into the cusp, you could deploy a valve. And so this is called the Jenna valve. It actually was FDA approved only 4 months ago, so after the testing and everything. And that's another option that structural cardiologists have. So structural cardiologists can fix aortic stenosis from the leg. They can fix aortic regurgitation from the leg. Now there's a little more detail to that, but in general. So that's the second solution that was done. And this is how this valve looks like. This is called the Jenna valve. And so it is FDA approved and available for use. So let's move on. So now we talked about the aortic valve. What about the mitral valve? So the most important thing for you to understand mitral is to look at this picture right here. This is called the surgeon's view. So if a surgeon cuts the heart from the top and looks into the heart, this is what he will see. And this is what we use as structuralists for all our procedures on the mitral. So this is the anterior leaflet because we said there's only two leaflets. This is the posterior leaflet, but even the anterior and posterior leaflet are divided into three segments: A1, A2, A3, P1, P2, P3. And this is the aortic valve. So when you're looking down, the aortic valve is on top. This is the anterior leaflet. This is the posterior leaflet. This is called the surgeon's view. This is the most important thing you have to understand. So what could cause problems in the mitral valve? So the way I explain this to patients is it could be the problem could be in the if you have a door in a frame, so the door of your house. The problem, if the door doesn't close, the problem could be in the door, which is the anterior or posterior leaflet, or it could be in the frame, which is the frame of the door, and so the door doesn't close. And in this case, it's this right here, the annulus of the valve. So if you have here a normal valve, here the problem, you have a prolapse of the valve, so the problem's in the valve itself. Here, the cord that holds the valve tore, so the problem is in the valve. And then over here, this patient could have AFib, which causes dilation of the top, and so the valve dilated. And then once the valve dilates, it separates the two leaflets from each other. So here, this is called primary. This is called secondary mitral regurgitation. So here's another patient. So 84-year-old male patient, he comes in, he has significant mitral insufficiency, so he's a lot of regurgitation. He has a significant medical history. This patient, if you were to offer him surgery, 6% to replace his valve, he has a 6% mortality, which is quite high. The other thing about this patient that we had is he had a many mental state examining score of 19 out of 30. So he's kind of demented. So no one's going to offer this patient surgery. So the other option is you tell this patient, go home, there's nothing that can be done. But this is where structural cardiology comes into play. So this is the case. This is when they did a transthoracic echo. You can see some leakiness right here. This is not normal. And then in order to visualize this, what's the best next step? You always get a TEE. As structuralists, we always get a TEE. And you can see right here, when the valve closes, there's going to be a tiny gap. And let's see, right there. So you see that tiny gap right there? The valve's not closing well because there is a ripped chordae, and so the valve keeps going. And this causes this jet right here, which is causing the patient significant breathing issue. So this is called eccentric jet. When the problem's in the valve, the jet does not go straight down the center, it goes to the side. And so, like I said, there's nothing to be done for this. It's surgical. This patient's not surgical. No one's going to offer him surgery. So the other option is someone out there invented, well, why can't we go in there from the leg, travel to the heart, and put what's similar to a paper clip and attach it to the valve? So if you look at the before and after, this is the before, this is after we put a mitral clip on it. This is the before in 3D. This is how we attached it. This is the before, this is the after. So we did a mitral clip on this patient, and it took 18 minutes. So in 18 minutes, so someone who was never, you would have otherwise told to go home, there's nothing that you can do. We were able to fix this problem in 18 minutes, right? And the patient feels like $1 million. So how do we do this? We travel in from the IVC, we go all the way to the heart. We have to puncture the inner atrial septum. And once we puncture the inner atrial septum, so we have to go from the right atrium to the left atrium, we come down and we put the paper clip on the valve. And this is how it looks when we do it under imaging. These are the delivery systems. So this is how the delivery system is. It's a very long tube, and we work from the back and the front to be able to do this safely and deliver it and be able to attach it. So that is in the case if you have a leaky valve. And so this patient right here has a surgical mitral valve. So he's already had surgery to his heart. So once you have surgery, it becomes a problem to do resurgery. So this patient already had surgery and the valve is no longer functioning. So what can you do in this example? Well, in this example, this is a TAVR valve. So we took the valve from the aortic stenosis, right? The valve that we treat aortic stenosis, and we flipped the valve because you have to put it in the direction of blood flow. And then we deployed that valve into the mitral valve. We used the surgical valve to anchor the mitral valve, the valve that we are going to put in to solve this problem. And the problem with this is the anterior leaflet. This is the posterior leaflet. If you come and put a valve right here into the mitral valve, right, you need something to hold it. That's number one. But number two, how long is this right here? Because if this anterior leaflet is very long, when you put the valve in, it's going to move upwards and it's going to touch this right here, touch the septum. And when it touches the septum, it's going to block the blood flow into the LVOT and the blood flow out of the aorta. You're going to kill the patient. So this is why sometimes, if you have seen lately, we have had this problem. So over the last year, we developed different 3 techniques to be specific for the mitral, called the Batman procedure, the Lampoon procedure, and the Sesame procedure. Again, you have to think outside the box, because these patients, they can't survive surgery. And if I put a valve in, I will kill them. So what could I do? Then we have to use one of these 3 procedures. So here's an example. This patient's only 60. So at 60 years old, are you going to tell the patient you can't do anything? Are you going to tell the patient, no, you go home, I'm sorry, there's nothing that we can do? That's not the case. You have to think about a solution of what can we do. This patient's only 60, but she's already had CABG, open heart surgery. She has a mechanical aortic valve already in place, and she has a valve in the mitral area that's not working. Okay, so right here, if you look at this image right here, this is the mitral valve, and you can see it's not opening at all. So this patient has severe mitral stenosis. And then we use CT scan to prove that and to size everything. So what did we decide to do in this case? So in this case, what we did, first of all, is you have to puncture the transseptal to get across. And what we did in this case, and I'm just going to go all the way, this is called the Batman procedure. So what's the Batman procedure? In order for me to put a valve in this lady safely, what I will do is I come in, and then you could see here in 3D, this is my equipment coming in. This is the leaflet that this is a TAVR valve that was sutured in here by a surgeon a long time ago. And if I put a valve in it, this will block the LVOT, like we said. So I come in here and I puncture this leaflet. I take a wire like a spear and very accurately, I push it into the leaflet. And once I push it into the leaflet, and I use electricity to do it. And the bubbles that you see here are me injecting D5 in order to conduct the electricity that's from outside the body into the body, and use my wire that has electricity. So the wire is, if you touch it, you'll get electrocuted. So now I use a wire with electricity to puncture the leaflet. And then once I do that, I bring a balloon and I inflate this balloon. And if you look very closely, you're going to see 2 things. You're going to see one thing right here. This balloon is opening up the septum right here. So the septum now is growing. And this is my balloon inside the leaflet, and I'm opening it up. And if you saw, I used one balloon and I inflated, and it opened the hole in the anterior leaflet so it can no longer block the blood flow outside the heart. And then I opened the septum to be able to pass my valve across, right? And then once I did that, this is what the leakage happened, right? The valve was not opening, but now it's leaking because I created that. What I did is I pretty much made a hole inside that leaflet. And then what I do after that is I bring my valve, which you saw in the first fluoro, I bring my valve, and now I deploy my valve inside the hole of the leaflet that I made. And then once I do that, right? Once I do that, this is how the valve looks like. So let me show you the valve expanding. Okay, this is how it looks like. Now the valve is opening and the blood is passing right here. If you see my arrow, the blood is leaving the heart without blockage. So again, You took a 60-year-old female who could not have surgery again, and you had a problem, and you had to think outside the box of how could I solve this problem? If I put a valve in her, she will die without me tearing the anterior leaflet. And that's how the Batman procedure was brought on. Now, and this is how the valve looks. Look, it's opening, blood flow is going through. This is a very good image, beautiful image of what was done. So now you take an 84-year-old female. So she's more on the older side, but still same exact concept. She has a history of a TAVR valve, but the patient now is significantly out of breath. She can't sleep. She can't eat because her valve is severely narrowed. So what do you do in this case? Well, in this case, the problem, you can see we don't have a valve to anchor to, but what we have is a 360 calcium around the mitral valve. So this is the mitral valve, and we use CT to find the calcium. But when we sent this to the company, so you send everything to a company, the company said this is prohibitive risk. So you have a prohibitive risk that you should not do this, because if you do this and put a valve in this calcium, the leaflet is going to block the LVOT that we showed earlier, and the patient will die. That's literally what the company said. But then we said, well, we can't, we have to help her out one way or another. This is where the lampoon procedure came into place. So this is how the valve looks. The valve is not really moving. It's not really opening. And there's a lot of, this is called smoke because blood's not really moving. And this is how it looks like. So this is the calcium around the valve, and there's calcium on the valve as well. And then the idea was, and this is just looking at it with color, it's very narrowed. So the idea was what we were going to do is the lampoon procedure. And the lampoon procedure pretty much is you create a blade inside the heart. Now, the technique, we're not going to go through it. It's a very complex procedure, but the ultimate goal is to form this. So this is called the flying V. And it's pretty much what we use if we want to cut something in the heart, in the body, without opening the chest. So this is a technique that came out recently. And so what this is called is the flying V. And so there is a wire on the tip right here that's exposed. And that wire, what we're going to do is put electricity on this wire, and we position the wire where we want, and we just pull it back, and what it's going to do, if it's going to slice the anterior leaflet of the mitral valve through the center. And so we position it using echo. So we position, so the wire's right here, and then we deliver the electricity, and this is me yanking back on it the first time, but there's so much calcium that I had to do 3 total times. And then by the time we did that, we created this slit right here. So now you could see there's more blood coming back, which means it was possible, right? Or it worked. And then once we did that, we quickly come back in, and then this is us inflating a balloon in the septum, because we need to go through the septum to get to the mitral valve. But ultimately, this is the valve, positioning the valve, using the calcium of the mitral valve that you see here to deploy the valve. And then this is the valve being deployed, and the calcium holding it in position. So and this is how it looks. So you took an 84-year-old female who's already had surgery, open heart surgery. No surgeon is going to do resurgery on her. And the options were you could go home and, pass away within a couple months, right? And it's going to be miserable because she's suffocating. All the blood is going back into her lungs. So it's as if she's drowning while walking. And then the company said you can't do this because if you put a valve, it's going to block the blood flow. So you were faced with a problem, and so you think outside the box. And that's what structural is. It's not about memorizing steps. It's about concepts. You understand concepts to be able to do procedures that have not been done before. And so this patient went home and is doing well. So then this is very actually cool. This came out recently. It's actually FDA approved. So we said that if there's a valve in the mitral valve, you use the valve you put your new valve in the valve. If you have calcium, you put your new valve in the calcium. But what about patients that don't have anything? They don't have a valve, they don't have calcium. Do we tell these patients to go home and not do anything? And so then there was a problem that needed to be fixed, and this is called the M3 valve. This was just FDA approved not too long ago. And what you do with this valve is you come and you put like a sling underneath the mitral valve. So this is you building the sling. So as you wrap it around the cords of the valve, and this is called the sling. And then when you do that, this is how it looks. So this patient had no calcium. This patient had no valve before. But what you did is you built a slingshot or a sling around it, and now you use that to put your valve in it. So then you come into the next shot. This is the same valve, and now you use what you had built to deploy this valve. So these patients would have had no option whatsoever. And then over here, you used what you had developed to do that. And so now you see the balloon's inflating, the valve's opening, and then the valve is going to go on those wires that you had placed, and then you get a fully deployed new mitral valve without having to do surgery. And this is how it looks. So again, there was a problem. You had to think outside the box. This is now FDA approved. It's available commercial. So we do this for our patients. And we actually were the first people to do it in the state of Texas. So all of Texas, we did the first 2 cases for this valve. So this is a very interesting case we had. So this patient has 2 mitral clips, and we talked about the clips earlier today. So you have 2 mitral clips, but this patient is still leaking. It comes back after 1 year of the 2 clips, and the patient is leaking, and you can see this. The orange color we said is bad, right? It's not supposed to go backwards. It has to go forward. So this patient is very symptomatic, very, very out of breath, but what could you do? Right? You could say, well, could I come back and put another clip in the middle? But there's no place to anchor it when you look at TEE. So the option was, well, do we leave this patient to be symptomatic, or what would you do? So what I did, this was one of my patients actually. And so what I did is, well, I was like, let's use an occluder, a device. So we all have PFO occluders. So if someone has a PFO, you put an occluder to occlude the PFO. Well, then I was like, why don't we take the PFO occluder and plug it in between and use these 2 clips to anchor it? And that's what we did. So here, what you see is a mitral clip, and this is a PFO occluder in between. And so this is what I'm talking about. For structural cardiology, you have to think outside the box. And obviously, it's not a one-man show. We have a team. There's always a team. There's always meetings. There's always discussions. There's multiple people that are involved in decision-making. It's not a one-man show. You have to understand this. It takes a team of structuralists to be able to do what we do and innovate what we have. And this is the last one. This is called the sesame procedure. And so like we said, if I go back a couple slides just to show you. So if the problem was if this comes all the way open and touches this, what about if the septum is thick, right? If the septum is thick, so if the septum is coming down like this, there's high chance of obstruction. So the Batman and Lampoon were ways to destroy or open this leaflet. Sesame is the opposite. Sesame is when you come down through this valve, puncture the septum, and then rip the septum. So doing a septectomy without actually opening the patient's chest. And so there's only 3 centers, I think, in all of the US that does this because it's a very risky procedure. So let's go back. So this is it. You come in through the valve, you wire through the septum, and what do you do again? You form the flying V. See, the flying V is the crucial point out of this. So once you form the flying V, and this was my patient, you pull back, and when I pulled back, the electricity in the tip of the wire rips the septum open as you see it right here. So it fillets it. And the idea is by doing that, you alleviate the obstruction that may happen. So this is another procedure that is done for the mitral. All right. So now let's move on. Now we're going to talk about the tricuspid valve. So this was a case we did 6 weeks ago. It's 45-year-old female. So she's only 45, right? She's extremely young. I mean, we will do whatever it takes to help this patient. She had previous tricuspid valve surgery, and now she prevents with narrowing of the valve. So how do you know there's a tricuspid valve? Because if you look at this image right here, and you look right here where my mouse is, that's the tricuspid valve. And you could see there's so much hardware in the heart that this patient has had multiple surgeries, a lot going on. So currently doing surgery on this patient is not the right option, right? So one idea sometimes is, well, if I do surgery on the patient when she's 45, she's going to need another valve when she's 55. So why don't I give her a transcatheter valve now and have her undergo surgery when she's 55 and reset the clock where they could put a new valve? And so that was one of the cases here. And so this case, like I said, we did this 6 weeks ago. We go in through the femoral vein. We cross right here. You see, we crossed through the tricuspid valve. And then what we did is we used the tricuspid valve. Again, in structural cardiology, you need something to anchor your equipment. And this one's easy because there's a tricuspid valve already there. And we'll use that valve to anchor the valve from the leg, the valve I'm going to put in. And so this is it. So this is the tricuspid valve right here. You see it in the background, and the valve is in the middle. And then we use a balloon to inflate our valve. And it's a very slow inflation, very meticulous, because you have to nail this. She's only 45, right? You cannot screw this up, in other words. And then slowly, slowly go up. Over here, you don't have to pace the heart because the pressures on the right side of the heart are small. And then there you go. You put a brand new valve inside her old malfunction tricuspid valve, and she's only 45 years old, right? And so that's one case. Now let's say we have a patient that does not have a tricuspid valve. How can we put a tricuspid valve in someone without a previous tricuspid valve where we can anchor our device? And the way that works is this is called the evoke valve. This is also approved. And we build our own anchor. And so this is the valve being deployed right here. And then this is going to anchor the valve in the right ventricle, and then the top part anchors it. And so this is called a evoke valve. So we have another option for the tricuspid valve. Now, for tricuspid intervention, we have not proven mortality benefit. So what do I mean by that? If you do aortic or mitral, patients will live longer. Right now for tricuspid, we haven't proven patients will live longer, but we have proven patients will have better from a symptomatic standpoint. They will feel better. And so this is called the evoke valve. And we can also, just like we could put clips on the mitral valve, we can actually do clips on the tricuspid valve, but I didn't put it here just because of the number of procedures and cases we're going through. But we can also put clips, tri-clips on the tricuspid valve. So again, we've seen options for the aortic valve. We've seen options for the mitral valve, whether it's leaking, whether it's narrowed, and how to fix it. And we've seen now 3 different options for the tricuspid valve. Imagine 10 years ago, not even 5 years ago, there was no mitral, there was no tricuspid. This is how quickly this field is evolving and expanding. All right. So we have a 68-year-old female, again, very young female, 68, extremely young. She has had a Ross procedure. And I don't know if you know what the Ross procedure is, but Ross procedure is when you cut the pulmonic valve when they're young out, you connect it into the aortic valve because the aortic valve is now not functioning, and then you just put a graft in the pulmonic valve. So that's the Ross procedure. And so this patient now comes in, she has the history of Ross procedure, and this was done by my colleagues this week. And the patient's very symptomatic, right? Because her valve is leaking. Again, orange is bad. Blood is supposed to go, let's go back to this. So blood is supposed to go, blood's supposed to go this way, but in this case, the blood's going backwards. So orange, like we said, orange is bad. We don't want orange, all right? And so So here, if you could see it, this is a balloon that's being inflated into the pulmonic valve. So now we're in pulmonic. So imagine we could fix pulmonic valves from the leg. And this is done to make sure that there's no obstruction of the coronaries. But long story short, so this patient had a Ross procedure, and then we used a valve to deploy it into her pulmonic valve. And that way, at 68, she doesn't have to have surgery. Okay, so let's backtrack a little. So if you look at this right here, what is this right here? So this is, now we're going to move on. So we did the aortic valve, the mitral valve, the tricuspid valve, pulmonic valve, and I showed you how we can fix these valves with different techniques, different procedures. Now we're going to shift gears. So a patient has atrial fibrillation. What is the problem with atrial fibrillation? The problem with atrial fibrillation is the blood. So the heart is supposed to do this. Atrial fibrillation, it does this. Blood slows down. Blood slows down into the left atrial appendage, causing clots. So this is why we put patients on what? Anticoagulation. So if someone has atrial fibrillation, they need to be on anticoagulation, especially if their CHA2DS2-VASc score is high, to prevent the clots from forming. And one of the perfect example, this is a patient that was sent to me in clinic for something else, and then we ended up finding this right here. This is a massive clot. Her entire left atrial appendage is occluded with clot, and it was starting to actually move. We could see it move out, and I had my surgeon do emergent surgery on her straight through the center, even though she was 80, to capture it before it dislodged and killed the lady. And so she's doing well now, but this is very important. Why do I bring this up? And the reason I bring this up is not everybody could be on anticoagulation. So you have atrial fibrillation, it causes clot, you put them on anticoagulation, but the patient starts bleeding. You have to stop the anticoagulation, but the risk of clot is now back to where, is high. Or the patient's falling. So the patient keeps falling. They have multiple falls. They hit their head. They're bleeding in the brain. You can't put them on anticoagulation. So what do we do in this situation? Well, that's where the Watchman and the amulet device have been developed, where we could go in there and close this hole without having to do open heart surgery. So this is how it looks under fluoro. You're coming in through the vein. You're going from the right atrium to the left atrium. You shoot contrast into the left system. So this is the left atrial appendage. So it's just a pocket in the left atrium. No one knows what it does, to be very honest with you, or the role that it entails. And so then after that, this is an amulet device, and this is the device being deployed into the left atrial appendage. And this is what it pretty much looks like. So this is an amulet device. So it's a small device. And then this right here is the Watchman device, because both of them can do the same exact thing. So that's simple. So if someone, as structuralists, we do get referred patients with atrial fibrillation that are either bleeding or falling, and we just put in a device in them. But there are people, electrophysiologists and other people who are not structurally trained that can do these procedures as well, at least this one. And the problem now, as structuralists, I get these patients sent to me to clinic where this patient, you can see right here, this is one of the patients that I got sent to me. He got sent to me because he got a Watchman procedure, but they kept this entire appendage open right here. So the procedure was not successful. If anything, now this patient's risk of clotting has increased dramatically. So then you have to now think outside the box as a structuralist, because it's not an appendage with nothing in it. It's an appendage with metal and clot, because now clot's formed over it, in it. And the patient can't be on anticoagulation. So this is a structural case where you have to think outside the box. So what I did is I sent this patient to get CT scans, and I did some measurements on these CT scans, and I decided to come back in and actually deploy a second device inside the first device, on top of the first device. So this is coming back in using echo, and then echo's helping to guide me. And then over here, I deploy a partial aspect of the device. And then over here, I deploy the full device. And then I'm happy. I'm looking at it on echo. And then I'm testing it. This is called a stability test. I'm making sure that if I let go of this device, it's not going to come flying out of the heart. And then this is what it looks at the end. So this is something else we commonly as structuralists get. And so that's the Watchman that was done by someone else. And then this is me fixing the problem that was created. And you can see here on echo, it looks really good on 3D device. Well, the size here was big that I could put a second device. What about if the size is not big, right? So this is another example. Another patient sent to me, and they had a Watchman, but when you shoot contrast, you see it's not supposed to all clot off. So in this case, what I did is I found the hole, so which takes a lot of patience. So I found the hole from where the leak is happening, and then I delivered. These are called coils, so they're like metal strings, and then I just filled it up with coils till it looks like the next shot right here. And then that way it's excluded, and the patient does not have risk of bleeding anymore. So now we're going to move on. So that's some other stuff, some of other procedures that we have. So now we're going to move on to VSD closures. So VSDs, this is a good example right here. You see this color right here where my mouse is? That's not supposed to be there. This is the ventricular septum, left ventricle, right ventricle. Blood's going from the left through a hole in the septum to the right. That's not good at all. So that's a VSD. And so we do some measurements on it. And then this is after a device is deployed. And you can see the device, one aspect of device, and then the other aspect of the device. And the one is in the left ventricle, right ventricle, and now it's occluded. So this is how it looks in the top right corner. This is another procedure that structural cardiologists now are able to, or they do. Okay. So this is a patient actually from this week, and this is a perfect example of a patient of structural cardiology. So this patient has a very high surgical risk. They have a lot of radiation to the chest. And so if you have radiation to the chest, the problem is even if you're 40, 50, 60, usually at 50, 60, the chest, you cannot clamp the aorta to survive surgery. So in other words, you can't survive surgery. So here's an example of a patient who has a TAVR valve, who has a mitral clip, and who is getting a tricuspid valve. So all three valves are being fixed from a tiny hole in the leg, because otherwise the patient can't have surgery. And so this is a good example of structural cardiology. Here's an example of a PFO closure. 20% of the population has PFOs. There's certain indications where they need to be closed, also can be closed from the leg in about 7 to 8 minutes. Here's an ASD closure, which is different from a PFO. This is, you use a balloon to size the hole, and then over here you can see it's a bigger device, and then you ultimately, this is a ASD closure. So besides fixing valves, besides fixing atrial appendages, structures are also specialized in closing holes in the heart. And then here's another example. So this patient is one of my patients as well. What is this? This is the ascending aorta, the aortic arch. This is coarctation of the aorta. So you read this all the time. I've never seen one, but that was my first one. This is a coarctation of the aorta. And this patient has significant pulse discrepancy between her radials, her femorals, and significant symptoms. And again, thinking outside the box, she cannot tolerate surgery. So go in from the leg, travel up, put a stent and balloon it, and open it back up for her. And she feels very, very good right now. So I think that's pretty much the nutshell of what I have. And then the last 4 slides that I put in every talk, don't forget, for med students, take care of yourself. It's a long journey. Don't forget where you come from. And if, this is why I said I graduated from your university. So if I can do it, every single one of you can do even more. And then the quote that I always use is, I'm in no competition with anyone or with no one. I'm simply trying to be better than the person I was yesterday. So that is pretty much it. I know it's a lot. Floor is open to questions if any do exist at this point.
Thank you, Dr. for this valuable session. We enjoyed it. Thank you for this precious webinar. So we have a couple of questions that those who registered via us. So the first question is that well, drawing on your extensive experience in structural cardiology, what are the qualities, decisions, and efforts help do you distinguish yourself and reach your current level of expertise?
Um, it's just time and practice. Don't be afraid to ask for help. And don't be afraid to ask for advice. I mean, despite everything I do, I every day, every single case, I call other people up, ask for their advice, ask for their expertise, run cases by them. This is a growing field. You as a person are constantly growing and maturing. You don't know everything. As soon as you think you know everything, you failed, because that's where mistakes happen and that's where you hurt patients. At the end of the day, every single patient should be treated like a family member. And so you want to do the best for them.
Okay, thank you. And our next question is that how do you stay current with advances in medicine and learn new procedural techniques and prepare for conferences?
You have to keep reading. So that's the thing. People think, oh yeah, I finished med school, I don't have to read anymore. Or oh yeah, I did my steps, I don't have to do anymore. You have to keep reading. If you want to be on the forefront of technology, right? The mitral, the tricuspid, that just literally came out brand new. The techniques, the different procedures we talked about. So education never stops. If you think you know everything, then you know nothing. That's the key here. So you got to keep have an open mind, keep learning, keep reading, go to conferences, participate wherever you can. Now, if that's not how you're built, then this is not the field for you.
Okay, what advices would you give to medical students and physicians hoping to pursue a career in interventional cardiology in the US?
Um, I mean, it depends on what phase they are in. Right now, what you need to focus on as a med student is um, medical school, um, your steps, and then you have to be a good internal medicine physician. So yes, if you know from now you want to do interventional cardiology, that's amazing, but it doesn't mean that you should slack as to be a terrible hospitalist or internal medicine physician. So again, just be patient and give everything its time. It will eventually come, and focus on each phase as it is.
Now, as structural heart interventions expand to younger and lower risk patients, how do you balance their less invasive nature against concerns regarding long-term durability compared with surgical treatment?
So that's where the heart team comes into play. So every single patient we assume will live till 100. So if I get a patient who's 70 years old, in my mind is I have to do what's right for the patient that will get him to 100. And so this is where a heart team approach comes into play. This is where, studying what's better. Do I give them a TAVR valve now, then do surgery later? Do I do surgery now, do TAVR valve later? This is a very complicated subject, but this is what structuralists train in. So when you do that extra year, structural fellowship is an extra year, and a lot of people don't want to do it. But if you do it, that's where you learn how to approach long-term issues and not just think short, um, be short-sighted with things.
Okay, now last question for me. With the global expansion of TAVR, how can healthcare systems balance its high upfront procedural costs against its potential long-term clinical and economic benefits?
So cost, it just depends on what country you're in. So in here, cost is TAVRs are, for example, are pretty much covered, and especially in the elderly, which is the majority of the patients that we see this problem. And unfortunately, as of now, I don't think it's covered, for example, in Jordan. Not that it's really done, so you have to pay out of pocket, which is expensive. for someone that for the economy in Jordan. So that takes a lot of work. I mean, hopefully one day it can become covered by insurances. Hopefully one day we can bring some of this technology back, right? A lot of this doesn't is not even anywhere close in our country. So hopefully one day we're able to bring, take some of this technology and expertise and help other less unfortunate people and countries.
Thank you, Doctor. Now I'll leave the participants to ask some questions. Is there anyone who wants to? Okay,
Yeah, yes,
Fahd.
please. Okay. Dr. Obadah, thank you so much for this insightful session. الله يعطيك ألف عافية يا رب.
Allah
Uh,
Afik.
quick background about me. My name is Faris Qubbaj. I'm a sixth-year medical student. Right now, I'm the president of the Cardiology Industry Group. I randomly saw your post 3 years ago on Facebook. Ever since then, I have followed you. I've been يعني ما شاء الله big fan, دكتور. إن شاء الله يعني one day we get to train under your
Allah
hands.
يخليك.
I'm very passionate about structural cardiology. I actually have two questions. My first question is, I have always wondered if transcatheter valves have the comparable long-term durability, let's say, to the surgical ones, particularly in younger patients, and what are the main factors that may limit their durability?
So that's a very, very good question. So for patients that are under 50 years old, so the way we classify this, let's say patients that are under 65, we do consider surgery as a first option compared to TAVR. Patients under 50, so bioprosthetic valve. So you have to understand there's two types of valve. There's mechanical valve, there's a bioprosthetic valve. Mechanical valves last patients all the rest of their lives. The problem with that is the patient has to be on warfarin. And so that any small cut, whatever, they're bleeding, they can't eat greens, etc. So there's a problem with that. Now it's much better these days. There's home warfarin testing machines and all that, but that's the mechanical valve lasts the longest. But bioprosthetic valves, whether TAVR or surgery, actually have almost the same lifespan. And so a TAVR valve average age is about 12 years. The thing that I didn't talk about today is actually, let's say you have a patient who's 70 years old, you put a TAVR valve in, and you put a big TAVR valve, let's say 26, 29. I could come back in 12 years and put another TAVR valve in that TAVR valve. And so you bought the patient another 12 years, right? And so that's the average.
Yeah, that was يعني my follow-up question, and I read a lot about the TAVR and TAVR procedures, but I've always wondered, could we do that, for example, for the mitral valve using mitral clip? Has that ever happened before?
So if I put a very big valve in a small sized artery, what ends up happening is the valve is not fully it's not fully open, and the valve will malfunction sooner. So it will malfunction years in advance. And so, but what we do discuss is, like I said, if you have a 68-year-old patient, so I know that he's going to need 3 or 70, let's say, he's going to need at least 3 valves to make it to 100. So these 3 valves could be 2 TAVR valves, 1 surgical, a TAVR, surgical, TAVR. So what's the best option? Do I do surgical now? So a lot of times we would probably do TAVR and then do surgery and then do TAVR again, because I can't put 3 valves into each other, but I could do 2 valves into each other as of
Sure.
now.
Yes.
Maybe technology will evolve even further, but that's how we do. We take a lot of thought in what we should do for a patient and what's the best long term for the patient.
Okay. And doctor, my last question is, it's a bit personal, but as someone who's very interested in structural cardiology, most doctors that I have looked up, they have actually done their first fellowship in interventional cardiology before structural. Do you think that would actually like help in interventional foundation overall? Well, and is there a compelling reason to do that, or can someone
You have to. You can't do structural.
without
You
intervention?
can't do structural before doing interventional.
So,
So
and
you
it's more
have to. So
prerequisite.
it's 3 years internal medicine, 3 years cardiology, 1 year interventional. So some people do some structural during their interventional year. I don't think those people can't do tricuspid and they can't do mitral. They could do TAVRs, they could do some Watchmans. But if you want to do real structural and the field is constantly evolving, then you should probably do another structural year, which is after the interventional year. And then is it possible, I see a question from Ali, is it possible to do structural fellowship in the US when I have done cardiology intervention outside the US? Yes. Actually, this year we have two structural fellows. One of them is from Italy. The other is actually from the Jam Al Urdaniya. He used to be, he did his internal medicine with Jam Al Urdaniya. He did his cardiology, Jam Al Urdaniya. Khalid Idjo is currently my structural fellow. So, and the idea is hopefully we'll train him and he's able to go back to Jordan and help people there. But yes, you can actually, because it's not ACMG accredited. So we're able to bring people from different places and train them for a year. Any other questions?
Okay, Muhammad, you can go.
Thank you, Dr. Obadah, for I have a question. Right. What do you think is the most challenging part of the structure of heart interventions that people outside the field usually don't appreciate?
So if I heard you correct, the toughest part of structural cardiology is honestly the unknown, because there's no guidelines, there's no there's a lot of times, like the case of the Watchman and the amulet, where I put an amulet, there's no data. Do I keep the patient on Eliquis? Do I put the patient on aspirin and Plavix? How long do I do the aspirin and Plavix? There's no data on that. That's a one case, or maybe there's a couple case reports on it, but there's no data on that. So you have to make decisions, and you don't know if that decision is going to hurt the patient or not. And that's, I think, the most, until this field is fully evolved, until people, we continually publish, and this is why we have to publish and go to conferences to get this word out, to learn from other people. The hardest thing is a lot of times I make decisions, but there's no data, there's no evidence. And so you make a best based on experience, based on talking to other people, but you worry that decision may hurt a patient. So is he going to come back? Am I going to get a phone call from the ER in 2 weeks that the patient had a stroke, right? That you have to live with that. And so that's the thing about this field, is in order to evolve it, you have to take on, unknown territory.
كنت عاوز اقول رايي بس في حاجه كده. محمد الشام من مصر، عملت روتيشن مع دكتور عباده، كان ليا الشرف يعني، وحقيقي دكتور عباده يعني من افضل الدكاتره على مستوى امريكا. وانا فاكر في مره في العياده جالنا 16 حاله، 14 منهم ريفيرد من اذر فيزيشنز عشان هم مش عارفين يعملوها، فيري فيري كومبلكس كيسز. شكرا يا دكتور عباده على المحاضره القيمه دي، وان شاء الله يعني منتظرين حضرتك في محاضرات تانيه.
Thank you, Muhammad. I do see a question. Will structural cardiology replace surgery? No. Surgeons will always be needed, but the volume has decreased dramatically, especially that the volume of TAVR has completely soared right now. It's over. So the TAVR procedures have passed surgical, but there's certain cases you still need surgeons, that we still refer to surgeons. Any other questions?
Yes, please, Dr. Obadah. There is a question from one of the audience. Can you ask what makes a good example of a student during rotation? And thank you.
So a good student during rotation. So I mean, I'll just talk about myself. For me, it's attentiveness. Showing interest. So I know, obviously you're all aware that I do bring students. I'm sorry if I'll be very honest. I get a lot of messages. I try my best to respond. So for anyone here that I haven't responded to your message, I'm trying to play catch up, but I get tons of requests and ton of messages. But for me, the students that have really stood out are the ones that show interest. They're very tentative. They're, because a lot of what I do is complex. And so when you're following and you're trying to see this stuff for the first time, you don't understand. But some people, you could see who's really interested or not. That's the biggest thing for me. Because at the end of the day, I do these rotations, for example, to help, to give back. You know, we do them. I don't take anything for it, nothing. And so, you know, it's just time that I rarely have, but still. So, what I think, in my opinion, the biggest thing, if you show interest, you will go very far, and it's genuine interest, not fake interest. And if you really show interest and you really want to be with whoever you're rotating with, not showing up late, not wanting to go home early, not, that stuff, for someone who's trying to help you and do something, and is doing it from his time, personal time, with no other gains from it. That's the biggest thing, I think, because that will either make it for you or ruin it for you. It doesn't even have to do about knowledge, right? Knowledge for me doesn't matter, because I don't expect anyone to show up and know how 80% of the stuff I'm going to say or do, right? So, but yeah, attentiveness and showing interest is the biggest and most important thing.
Okay, are there any questions? Okay, it looks like there are none. Lastly, thank you, Doctor, for this session. It was very valuable, and it was a pleasure to meet you. And we hope that we can meet you again in future webinars.
Thank you, guys. Thank you for
Thank
having
you.
me.
يعطيك الف عافيه دكتور عباده، شكرا كثير.
الله
يعطيك
يعافيك.
الف عافيه دكتور.
الله يعافيكم.
Thank you, thank you.
مع السلامة.
Infection with increased ketones in blood or urine, and infection between and around the anus both may be fatal. Airway reactions, dehydration, urinary tract, or genital yeast infections